Welcome to MD Longevity Lab, where we're playing the long game. This is a podcast where science meets real life with expert insights, practical tips, and real-world tools to not only live longer, but live better. Our aim is to radically change the way medicine is practiced and enable individuals to age gracefully, maintaining health span and vitality well into their later years. We're your hosts, Dr. Nisha and Dr. Vikas Patel, physicians, partners in life, and parents balancing work, wellness, and everything in between. Let's dive in.
Welcome back to the MD Longevity Lab podcast, Playing the Long Game. I'm Dr. Nisha Patel.
And I'm Dr. Vikas Patel. Today is a special one because we're joined by somebody who has probably influenced every longevity conversation happening today, at least to some degree, whether people realize it or not.
He's a scientist whose work has shaped how we think about aging, health span, mTOR, and maybe one of the most misunderstood medications in the longevity space, Rapamycin.
We are talking about none other than Dr. Matt Kaeberlein. He is a world-leading scientist in the biology of aging. He notably completed his PhD from MIT in a mere 4 years and 3 months, I think, at the top of his class. He's also the founder of OptiSpan, which is a health span and longevity focused clinic, very similar to what we do at MD Longevity Lab, focused a lot on preventive medicine. He is the former director of the Healthy Aging and Longevity Research Institute at the University of Washington. His research work has really shaped much of our modern understanding of a few things that we'll get into in the podcast today, including mTOR, rapamycin, just translational geroscience. And he did some of this work initially starting at MIT while identifying some of the genes responsible for aging in yeast. He is also notably the co-founder of the Dog Aging Project, and I believe parent to 3 dogs currently.
Yeah.
And then something that Nisha and I have really enjoyed is that he's really a scientist who's known for nuance, integrity, and really elevating evidence over the hype in the longevity space, which is a common pitfall or trap that we see quite frequently.
You are one of our favorite people because you tell the truth even when it's inconvenient. And so we are so excited to dive into longevity through the lens of someone who really understands the science. Matt, thank you so much for being here.
Well, thank you for that kind introduction. That was really nice and appreciated. And it's a pleasure to be able to join you today. I'm looking forward to it.
So we're going to get started with a couple basics here. I wanted your take on what you think the biggest shift is going to be in how we define and measure health span in the coming decades.
Sure. I mean, I think maybe the way I would start the conversation is that I think of health span as a really useful concept. I'm not really sure that we should try to measure health span. And what I mean by that is I think even to some extent, when we talk about trying to measure health span, the word itself is a little bit problematic because of that span piece, right? It implies that there is a time or a length to health, which implies that for an individual, health goes from something you have to something you don't have overnight. And of course, that's not the reality for anyone, right? So I think maybe the way we should think about it is that health span is multifactorial. It's made up of lots of different aspects of function and emotional health and molecular biomarkers that we are, I think, becoming better able to assess each of those individually and understand what they mean, and then more importantly, what to do about it. So I think the way that I see health span changing going forward, and I think we're already starting to see this, is number one, a more widespread recognition of how important it is to take a proactive approach to health, right? And to get ahead of health and not wait until people are sick before we try to do anything about it. So proactive, preventative approaches, I think, are going to continue to become an emphasis going forward. And then I think also as the tools become better developed and as AI gets integrated, we're going to continue to see real opportunities for personalized approaches to health span extension or health promotion. And I think this is something that a lot of people have been excited about for a long time, the idea of personalized medicine. To date, that has really been fairly rudimentary, and we don't have a lot of concrete examples of how this can be done well. But I think, with the new AI tools that are coming online and with the sort of plethora of new diagnostics that we have at our disposal, that there are real opportunities for true starting to get towards personalized approaches to preventative healthcare. So I think that's probably those are the obvious things that are going to continue to get better and become widely implemented in the next 3-5 years looking forward.
One thing I wanted to pick your brain about, there are so many of these direct to consumer biological age tests with no oversight, no medical oversight. We have our opinions on those, but I would love to hear your take on it.
Sure. Yeah, I'm very opinionated about this topic. I will say, I was just talking about the new tools, the new diagnostics that we have at our disposal to assess different aspects of health. I think the biological age tests sort of overlap with that set of diagnostics, in the sense that in the research world, there has been a lot of progress at, first of all, understanding what are some of the things that we can measure that tell us about health, which is correlated to biological age, right? So there's been a lot of advances, and I think the development of these biological aging clocks, is what most people call them, has been an important research advance for sure in the field. So first of all, it might be useful to just appreciate what a biological aging clock actually is fundamentally. So biological aging clocks are just a collection of individual biomarkers of aging. And a biomarker of aging is just something that changes in a predictable way across the population with chronological age. Okay, so there are tons of those, like skin wrinkles, graying hair, testosterone levels in men, VO2 max, grip strength. You can see these things at molecular levels as well. Metabolites that change with age, proteins that change with age. All the clocks is taking a bunch of those and using complicated math and usually machine learning to pick a subset of biomarkers, anywhere from a few dozen to a few hundred, and then creating a linear equation where you weight each biomarker differently to give you a correlation to something that's associated with health. And that can either be chronological age, those are the generation 1 clocks, or it can be risk of dying, mortality risk, or risk of developing a age-related disease. Those are generation 2 clocks. So you're using a collection of biomarkers to create a predictive algorithm, a correlation to something of interest. Chronological age, your birthday, or your likelihood of dying, or your likelihood of getting sick. That's what aging clocks are. And just for a little bit of nuance, there is a different flavor of aging clocks, which some people call generation 3 clocks, which instead of predicting chronological age or your risk of dying, predict the likelihood that your health is going to change over the next 5 years, 10 years. Those are called pace of aging clocks. So they're predicting the rate of change in health. Okay, so these are conceptually really fascinating. I think in the research world have taught us a lot about the biology of aging and will continue to teach us a lot about the biology of aging. And they work pretty well at the population level. If you have data from 100,000 people, you can develop really good correlations. Where they don't work so well, even in the research world, is at the individual level. So every measurement has some error associated with it. The best clocks have an error of, plus or minus 5 years, maybe a little bit less than that, maybe a little bit more than that. So that means the standard deviation from the true value for whatever they're estimating, chronological age or risk of dying, is going to be 5 years. So 2/3 of the time it'll be less than that, 1/3 of the time it'll be more than that. Okay, so that's useful to understand. That's in the research world, perfect conditions. The problem we've got is we've had a bunch of direct-to-consumer companies start selling these tests, marketing them to people. They're not doing these things under the most perfect conditions. And in fact, we have no idea what the error rates are. I mean, there are lots of problems with the direct-to-consumer test, but to my mind, that's the fundamental problem. You can't use them because you don't know what the error is. Period, full stop.
So when researchers have some sort of intervention, and one way of doing these aging clocks are methylation tests for DNA, and they seem to imply that their technology, when they have introduced some sort of intervention and they're tracking methylation trends on DNA, that it does actually give them true insight. But then when we look at the consumer grade methylation tests,
Yeah.
it's kind of all over the place.
Yeah. So a couple things to say there. Number one, yes, I think in the research world, there are a small number of quality studies that have looked at the way these methylation clocks. And again, I know it's getting a little bit in the weeds, but it's probably worth appreciating. The epigenetic clocks or methylation clocks are just one flavor of aging clocks. They're the ones that were sort of first popularized, and they're the ones that have been used the most in the research world. But you can develop comparable, maybe even more precise aging clocks using other types of biological data, proteome, metabolome, transcriptome, microbiome, maybe even, or functional measures like I was alluding to, grip strength and VO2 max and body composition. So the epigenetic or methylation clocks are just one flavor, but they are the most common flavor. So you're right. There are studies that have been published, many studies that have been published that correlate changes in these epigenetic clocks to interventions. They could be lifestyle interventions, drugs, to major life events, pregnancy, menopause, to environmental exposures. Some of those studies are high quality. The vast majority are low quality, in my opinion, but there are lots of them out there. And it's hard, I think, for the average person. Certainly, it's hard for me as a scientist. It takes me time to dive into the studies and really look at them to know which are high quality and which are low quality. So all of that is being said is that I think at the population level, when done well, these clocks can actually tell you something about how an environmental change, a major life event, stressful event, maybe even medications or lifestyle interventions are impacting the underlying aging biology, but it's an indirect estimate of aging biology. I think that's the other thing that's worth appreciating. If you ever hear anybody say, and I guarantee if you stay in this space long enough, you will, if you ever hear anybody say, I measured biological age using this test, they either A, don't understand how the test works, or B, they are intentionally telling you something that is not true. And you can consider how you feel about that. I know how I feel about that. Biological aging clocks do not measure biological age. They measure either average methylation state at a subset of sites, or protein abundances, or transcript abundances, or whatever it is they're measuring. It's not biological age. And those are correlated to what they're estimating, which is also not biological age. It's chronological age, or mortality risk, or risk of developing cancer. So there's a lot of, I think, sloppy language and misunderstanding around what these tests actually do, how they work, and whether or not you can rely on them. Again, my biggest concern is that in the direct-to-consumer space, all bets are off because we just don't know what the error rate is for what the tests are supposed to be estimating. Most of the direct-to-consumer tests are estimating mortality risk. Those are the algorithms that they use, which is fine. If we had it, if we knew what the error rate was, if we knew that was plus or minus 5 years, then we could put statistical bounds on the test and we could say, okay, with a 66% probability, a change of more than 5 years is meaningful, right? But we don't know what the error rates are. My intuition, based off of some evidence, is that the error rates are much greater than 5 years. And for people who are interested, like if you're a data nerd, I would just suggest if you want to do an interesting thought experiment, because a lot of people are, say, buying these tests quarterly and taking them quarterly, right? If you want to do an interesting thought experiment, whatever your age is, think about your age, put that into ChatGPT and say, give me a set of 10 series of 4 numbers based off of a normal distribution at whatever your age is. Let's say you're 50, around 50 with a standard deviation of 5. That's the result you would get by chance if you did these tests 4 times quarterly, right? And you did everything right. Your biological age didn't move. And look at the distribution. You're going to look at that and then think about what you would think if you got those results back from your biological age test. It's all over the map. These things, in my view, are completely useless at this point. And that's the best case scenario. I guarantee you the error rate is more than 5 years on any direct-to-consumer facing biological age test today.
No, you did the methylation test on yourself the same day, right? Same company.
Yeah.
And what were your results?
Yeah. So, I mean, it's complicated the way I did the experiment, but basically what I did was I did 4 different companies. I did each test in duplicate, and it was same sample, same days. Some of the companies used saliva, some of them used blood, which makes it more complicated, but it was the same samples. And the results were I think, interesting and informative. For 3 of the companies, the 2 replicates were relatively close together within 5 years of each other. When you look across the 4 companies, the spread was more than 20 years. And for one company, the spread was almost 20 years. It was like 15 years for the 2 replicates. So again, first of all, it's not a large enough set. Like 2 replicates isn't a large enough set for me to say anything other than there's a lot of noise in the system. And when you look across the industry, it's a complete freaking mess, is my take home from that experiment. I think in some ways that experiment was good because it brought attention and people can point to it, but it's also a little bit distracting in that you don't even need to do the experiment. If you're at all quantitatively inclined, that sort of mathematical thought experiment I just laid out, if you understand what a normal distribution is and what a standard deviation is, and the magnitude of effect we're talking about, even in the very best case scenario, like the Horvath clock, the gold standard, has an error of 3.6 years. That's the very, very best you're ever going to get. And it's still 3.6 standard deviation. So if you understand that and you model it, you will very quickly realize how useless these tests are right now at the individual level, because I'm telling you, in the direct to consumer space, the error rate is at least 3 times what it is for the Horvath.
I think that's reassuring, and it's a good number for our patients that you just can't panic over a single number that you get from these things. I think we field a couple phone calls or inquiries every week on a patient who specifically asks us, do we run these tests? And then we have to go into this lengthy explanation, as you just gave, about why this may not be a test that's worth your time.
And there's so many more useful tests, right? VO2 max, your full body DEXA scan. So
I think that's really the important message, right? Is that we have really informative and actionable biomarkers. Of course, people want to get to a single number. I understand the desire for that, but I think it's not nearly as useful as looking at a collection of health-related biomarkers that span the different systems of health, so you can really get a feel for where the biggest opportunities are. It might be worth saying, the one type of aging clock I'm relatively bullish on right now are these clinical chemistry clocks, like Lineage2 or Enable-Age, that use things that we can measure from blood or urine and go to reference laboratories like LabCorp or Quest. I think those are quite powerful. They're trained on mortality. And what you can get from that a picture of, for a given individual, which biomarkers, if you can move them, are most likely to move the risk for mortality. Now, that makes the assumption, of course, that these things are faithfully representing mortality risk. But when the biomarkers are directionally consistent with what we've learned from decades of clinical practice, it makes sense, right? If you take the Lineage2 test and it tells you that for you, you're going to get the biggest effect on mortality risk if you get your blood pressure under control and your A1C, those are the things you can focus on right away. And so there, I think those tests are potentially valuable because they give you actionable insights that are potentially also behavior modifying. You can talk to a patient and say, look, this algorithm is telling us that for you, it's most likely if we fix these things, you're going to have a big impact on your risk of dying or your risk of developing cancer, whatever the case is. Those are the kinds of tests I like because, number one, we do know what the error is because we know what the error rate is for each of those individual measurements. Those reference laboratories are required by regulatory bodies to be within a certain tolerance for error. So they're clinically validated. We know the error rates and they're actionable. And I think those are the 2 pieces we need to get in place for the other aging clocks before they can reliably be used in a clinical setting.
I think that's exciting. I think leveraging AI, which we'll talk a little bit about later, by feeding it these biomarkers and figuring out, because we do have data on, hey, if your hemoglobin A1C is 8.3, right? From a mortality standpoint, what does that mean for you? How much higher mortality rate do you have at that A1C versus at 6.0? So I think that's where these tests are looking promising, and it's very interesting what you bring up. I'd like to get into a little bit more of things that you specialize in. And this may be a little bit new to some of the listeners, but I'd like to see if you could explain to them what mTOR is and why it's so central to aging biology.
Sure. So I think from a very high level, you can think of mTOR as sort of a gatekeeper for the cell. And in terms of sensing the environment and making the fundamental decision, is the environment appropriate for growth and reproduction? Okay. mTOR is a protein that helps the cell make that decision. And it's one of the key players in that decision. And that's a really important decision. If you think about evolutionary timescales, every organism that has ever existed has had to make that decision, sense the environment, and then determine, is it a good time to grow and reproduce, or is it better to shut down growth and become stress resistant and wait for the environment to improve? And then if you think about what in the environment helps inform that decision, it's a pretty small number of key factors that inform that decision. Temperature is going to be important. If it's an oxygen consuming organism with mitochondria, oxygen abundance is going to be important. And food is going to be important. And TOR senses all of those, but it is mostly interested in food. So a lot of people will call it a nutrient responsive sensor. So when nutrient levels are high, TOR gets activated, and that tells the cell, okay, this is a good time to have babies because you have lots of food to feed them. When nutrient levels are low, that turns down TOR, and that tells the cell, okay, let's shut down growth and reproduction. Let's become stress resistant and hope the environment gets better in the future. So that's basically what TOR does. It's a nutrient responsive kinase is the biochemical term, and that just means that it puts phosphate groups on other proteins and controls signaling. So it's a signaling molecule that senses the environment and then signals growth versus reproduction versus stress resistance. A lot of people got interested in TOR, many years ago as an anti-cancer target because it's so involved in cell division, right? Growth. And so people began studying it for anti-cancer purposes. It actually got FDA approved. The drug that targets TOR, which we'll probably talk about, is called Rapamycin. It's an inhibitor of TOR. That actually got approved as an immune suppressant because immune cells are rapidly dividing when you get an infection. It's used to prevent organ transplant rejection in that context. So that's how TOR got studied clinically. But sort of in parallel, several labs around 2003 kind of stumbled on TOR as an important target for longevity. And I was fortunate enough to be involved in those studies as a postdoc, where we were working in yeast. I was working with Brian Kennedy and Stan Fields at this point, but other people were working in C. elegans, and Sidney Brenner's lab and Pankaj Kapahi were working in fruit flies. Again, this happens in science sometimes completely independently, completely different lines of research. We all converged on TOR as being a central regulator of lifespan in each of those organisms. And I think, 4 papers came out within a year of each other, all pointing to TOR as regulating lifespan in 3 different organisms that are separated by billions of years of evolution. People paid attention because it's like, wow, this seems to be really important. And what we've learned since then is that also seems to be the case in mammals. So mice and rats, and some evidence even in non-human primates, that when you turn down TOR, you slow aging, the animals live longer. Not only that, but they seem to be healthier. So turning down TOR preserves function in pretty much every tissue and organ where people have looked in mammals like mice and rats. So it really seems like TOR is a highly evolutionarily conserved, really important component of the biological aging network. And when we turn it down, as long as we don't turn it down too far, we can slow aging and increase lifespan, at least in laboratory animals. And I think obviously one of the big questions does it work the same way in the real world? Could we do the same thing in people? Or you mentioned I'm part of the Dog Aging Project. We're interested in knowing whether we can have a positive impact on our lifespan and health span of our companion animals as well. So that's kind of the unknown. That's the frontier right now, is to what extent can we modulate mTOR to slow aging outside of the laboratory?
We know rapamycin is an immunosuppressant.
Right.
If you ask most physicians, I think they're clueless when it comes to rapamycin in the longevity space.
Yeah, sure. And I mean, again, absolutely, that was the case 5 years ago. I think almost every doctor I talked to was like, why would you even think about giving an immunosuppressant to a healthy person? That's crazy. Now I think that's changing. People have at least heard of it. But I think you're right still. There's a lot of misperception and misunderstanding about rapamycin. So again, rapamycin is a small molecule inhibitor of mTOR. So rapamycin turns down mTOR. And in many ways, you can think of it as tricking the cell or the organism into thinking there's not very much food around. Because when there's low nutrients, that also turns down mTOR. So rapamycin turns down mTOR even when there's lots of food around. It inhibits growth and cell division. As I alluded to, it was first developed clinically and FDA approved to prevent organ transplant rejection. At high doses in people taking other immunosuppressants, rapamycin has immunosuppressant properties and will reduce the likelihood of rejection of an implanted organ. That's what it was approved for. It works well in that capacity. Also, in that context, there are side effects associated with rapamycin. They're not terrible, but it's got a black box warning. It's got some bad reputation associated with it because of the way it was developed, approved, and used at high doses in these patients. I think the most common side effect is in organ transplant patients, significant mouth sores or ulcers in the mouth. But it also has some concerning side effects around what I would call pseudo-diabetes. So something that looks like diabetes based on insulin sensitivity and glucose measurements, high lipids, hyperlipidemia being one of the common side effects. And then, of course, people are worried about increased risk of infection because it's an immunosuppressant, right? So those are the things people get concerned about when you talk about using rapamycin in healthy people outside of the context of organ transplant. So why would you think about doing that? I mean, one reason is because of all of the evidence in laboratory animals that rapamycin can slow aging. Obviously, that doesn't mean it's going to slow aging in people, but everything I know about biology tells me it's going to slow aging in people if we can get the dose right, slow biological aging. It is important to say, just because something slows biological aging in people, that doesn't mean it's going to make you live longer and healthier if there are side effects that are going to offset the benefits. So to me, I think there are two questions about rapamycin use off-label at this point in my mind. One is, what is the right dose, duration, frequency to get the beneficial effects on biological aging in people? Again, I can't prove it slows aging in people, but everything I know about biology tells me it will to some extent. Might not be as effective as it is in mice, but it's going to slow aging to some extent in people. Okay, so how do we do that? What's the right dose, duration, all of that stuff? And then, are there going to be side effects at that dose, that duration, that regimen that are so counterproductive that it's not worth it, even if you are aging more slowly? Those are the two questions I think we don't fundamentally know the answer to at this point. So what has evolved is a sort of off-label use community that is centered around a certain dosing schedule. But the reality is lots of people are doing lots of different things. We don't have a ton of, I would say, high quality, certainly not much, double-blind, randomized, placebo-controlled clinical trial level data yet to really be able to have a lot of confidence what people should be doing, what's effective, what's not effective. Happy to talk about what we do know. One thing I think that is worth noting, and this is my, largest frustration with rapamycin, is unlike some other things, we don't have great biomarkers to use to tell us for you as an individual, if you're taking rapamycin, is it helping? Are you taking the right dose? We don't have obvious biomarkers that can tell us with a high degree of confidence that rapamycin is working for you. And if people don't know what I mean by that, I think as a sort of interesting counterexample, another drug we can talk about if you want to are these things called SGLT2 inhibitors, right? These are anti-diabetes drugs. I'm sure you guys are very familiar with these drugs. Basically what they do is they cause you to pee out more glucose. They reduce kidney reuptake by the glucose. So it lowers your blood glucose because you're just getting it all out in your urine. There we've got really good biomarkers. We can measure fasting glucose levels. We can measure insulin sensitivity. So that's a case where there's a drug that also might have geroprotective anti-aging effects where we got a great biomarker or set of biomarkers to look at. So that to me is really the challenge with rapamycin right now is we don't have something like insulin sensitivity to look at and say, we know we've got you dialed in with your rapamycin regimen.
You took rapamycin for an injury, correct?
That's right. Yeah. So, I mean, if you had asked me, that was in 2020. So we're 5 years out now. But I mean, if you had asked me 7 years ago, should people be taking rapamycin off label? I would have been like, no, I don't think anybody should take rapamycin off label. So I was a pretty conservative academic. That's the way a lot of academics are, which is fine. I think there's a right balance of conservatism and being willing to be risky, right? And figuring out that right risk reward ratio. But I had a personal experience where I, after a long process of having this very painful shoulder condition that got to the point where I couldn't sleep, I couldn't go across the street and throw a ball with my son. And I was a pretty stereotypical, 40-something-year-old man where I was like, I'm going to push through it. It's going to go away. I'm not going to go to the doctor. and it didn't go away. It got worse. I finally got to the point.
What that's like.
Yeah.
I know, right? Thing, yeah. So it was dumb. I admit it was dumb. But anyways, it had to get to the point where I couldn't throw a ball with my son before I would go to the doctor and say, okay, I need to get this fixed. Now, also, like a stereotypical 40-something guy who thinks he knows a lot, I was sure I had a torn rotator cuff. So I go to my primary care doctor and I'm like, I have a torn rotator cuff. I need you to give me a referral to a specialist so I can get it fixed. And he was like, no, I want you to go to physical therapy, blah, blah, blah. So I did that. That made it worse. So I went back to him and I'm like, okay, I tried it your way. Give me the referral to the specialist because I need surgery to get this fixed. And so he did. And within like 5 minutes, the orthopedic specialist was like, you don't have a torn rotator cuff. You have adhesive capsulitis. And I was like, what is adhesive capsulitis? It's like, it's called frozen shoulder. It's inflammation of the shoulder capsule. It usually is more common in women than in men, but it happens in people your age. And I was like, my age, give me that stuff. So, and then he's like, he's like, I want you to go back to physical therapy and maybe it'll go away in a year. And I was like, God, I can't live like this for a year. So I vividly remember I'm like in the car, I'm pissed off, I'm depressed. And I start thinking to myself, okay, this is an age-related inflammatory condition. At that time, we were studying rapamycin in my lab. We'd shown that you could increase lifespan in mice with a 3-month treatment in old age. And then we'd gone on to looking at periodontal disease, which is an age-related inflammatory condition in the mouth. And we'd shown, we had this data that treating old mice with rapamycin dramatically turned down inflammation in the oral cavity, in the gums. And so I'm thinking to myself, okay, this is inflammation in the shoulder capsule. It's probably related to inflammation in the gums. Maybe rapamycin would work for my frozen shoulder. And again, I'm very lucky in the sense that I've got access to doctors who will work with me and were willing to prescribe me rapamycin so I could do this self-experiment coming from, a relatively informed place. And, I can't 100% rule out placebo effect. All I can tell you is that within 10 weeks, I was 95% range of motion back and the pain was pretty much completely gone. And so it's such a biologically plausible mechanism that I really, it's hard for me not to believe that it was the rapamycin that had that effect. So that was my personal experience. But again, it took me having that personal situation to make the leap to trying rapamycin. I think before that, and to be fair, we didn't have a lot of data on off-label use of rapamycin in 2019, early 2020. Most of it came from the studies that Joan Manick did, and those might be worth talking about if you'd like to go into those. But outside of those clinical trials, we didn't have a lot of data on off-label use of rapamycin, so we didn't really know what the risks looked like at that point. I think now we know the risks when done, in a way that is reasonable and that most people are using it. The risks seem very, very low at this point.
It sounds like, and I know that this has been explained before, essentially like a lot of people, even to this day, I'll get patients talk to me about fasting and the benefits of fasting and what it does to mTOR. And it sounds like this is kind of the theory behind what rapamycin is doing, and people are trying to replicate it to some degree in these fasting states.
So I think that's true. Again, fasting is a pretty misunderstood intervention, at least when you look at what we know from the biology of aging, right? And again, when we talk about is something a longevity intervention, we don't have the ability to prove definitively whether any intervention is a longevity intervention in people, right? Outside of the things where we can say with a high degree of confidence, like don't smoke, you're more likely to live longer, eat a healthy diet. So we have to go to the animal studies. And that's where I think there's a lot of misinformation and confusion about fasting from the animal studies. Yeah. So fasting is a longevity intervention when it is paired with caloric restriction, okay? When the animals make up for what they don't eat on the fasting days, there's little to no longevity benefit. So at least in laboratory animals, mice and rats, fasting per se, when it's isocaloric, has little to no longevity effect. Fasting will absolutely turn down mTOR. And in mice, that happens pretty quickly. But I think people need to understand a 24-hour fast in a mouse is fundamentally different from a metabolic perspective than a 24-hour fast in a human. I don't think anybody knows exactly how the math works out, but it's probably more like a 3 or 4 day fast in a human in many ways, not in every way, but in many ways. So going from the animal studies to humans when it comes to fasting, I think is just very risky, and it's filled with a lot of misinformation. I think this is now, and so that's the data. My personal opinion is I would not approach fasting from the perspective of fasting as a longevity intervention. I think for some people, fasting can be a really powerful way to control body weight, to control overeating, and you need to be careful that you are eating a high quality diet if you're going to do regular fasting, right? I think that's an area where people often make mistakes. But I would not approach it from the perspective of longevity. And again, this is again getting in the weeds a little bit, but even the terminology is a little problematic because some people, when they say fasting, mean time restricted eating, like shrinking their meals down to 8 hours or 12 hours. Some people mean a 24-hour fast. Some people mean a multi-day water only fast. So those are all going to have different biological effects, and people need to appreciate they are not biologically equivalent. I think all of them can be useful for certain people in certain conditions. Again, outside of caloric restriction, I don't think there's a lot of evidence that fasting is a longevity intervention. And again, this is maybe a useful counter to even rapamycin in the sense that, I mentioned just because something slows aging in people doesn't mean it's going to make you live longer and healthier. I think caloric restriction, and this is speculation on my part, but I think caloric restriction falls into that category. At least the levels of caloric restriction that robustly slow aging in mice, 60% caloric restriction, 50% caloric restriction. I think in people, the data we've got, which is imperfect, but from things like epigenetic aging clocks and other biomarkers, seem to show that caloric restriction slows aging in people biologically. And I think most people, if they were to practice that level of caloric restriction, would not live longer. They certainly wouldn't live better for most people. I don't think they'd actually live longer because mice in the laboratory don't die from frailty. They don't die from falls and fractures. They don't die from sarcopenia. But people practicing that level of caloric restriction, unless you really have the nutrition dialed in and you're really doing a lot of resistance training, are going to be at higher risk for those things. And so I think both from a quality and quantity of life perspective, I'm just going to call them side effects of caloric restriction are going to offset the benefits of slower biological aging. That may be a good, at least thought experiment for why people can understand, even if you're aging more slowly biologically, that may not mean you're going to live longer and be healthier in the long run. So, sorry, that was a big tangent. Yes, fasting mimics rapamycin, but they're not identical. So the other way I would think about it is that fasting or caloric restriction is going to have thousands of other biochemical effects that rapamycin doesn't have. Rapamycin is a very specific biochemical inhibitor of mTOR. As far as we know, it doesn't have any other major off-target effects biochemically, whereas caloric restriction or fasting are going to completely rewire metabolism in ways that rapamycin doesn't. So I think of them as overlapping but distinct. Rapamycin is very clean in the biochemical sense. Fasting and caloric restriction are very dirty in a biochemical sense. That's not meant to be a pejorative. It's just a sort of reflection of what's happening at the biochemical level.
Can you also talk a little bit? I know this is not part of your expertise, but just a little bit, because we hear it so much now, about what Klotho is and how it might relate to mTOR.
Sure. Yeah. So there's definitely so I think, first of all, macro level, I think of the biology of aging as a network of interacting proteins and metabolites and RNAs. And so there's this network of factors that seem to modulate the rate of biological aging. And the readout of that are the hallmarks of aging. Again, that's an oversimplification, but for lack of a better way of saying it in a concise framework, the action of that network is affecting the hallmarks of aging, which is what we perceive as biological aging. Okay. So Klotho and mTOR are both in that network, and they both seem to be important, what I would call nodes in that network, and also useful nodes. A useful node in the network is something we can target from an intervention perspective, and we see that it has changes that we can measure on biological aging. Those changes being lifespan, healthspan metrics, epigenetic aging clocks, things like that. So Klotho is interesting. So Klotho, I think we know a lot less about Klotho and how it's working from a biochemical perspective to affect aging biology. It's what's called a transmembrane co-receptor for something called FGF23, fibroblast growth factor 23, and it regulates a bunch of stuff, including oxidative stress, IGF-1 signaling, inflammation, all the things you would expect it to regulate if it's regulating biological aging. But I don't think we really understand how. The data here is interesting, and I think it's interesting that there's a lot of excitement about Klotho in the longevity community, but there's a lot less known about how it's working than there are for things like rapamycin or AMP kinase or some of the other common players in that network. So what we do know in mice is if a mouse is lacking Klotho, so you knock out Klotho in a mouse, it gets sick early, it dies early, and it seems to show some phenotypes of accelerated aging. So it's consistent with the idea that the mouse are aging more rapidly. And if you overexpress Klotho, the mice live longer. And this hasn't been looked at as extensively as it has with mTOR and rapamycin, seem to be healthier across at least a few of the major organ and tissue systems, particularly brain, heart function, things like that, where people have done sort of deep dives. So that certainly is consistent with the idea that Klotho is regulating biological aging, and we can change aging either direction in laboratory animals. I think the cool thing about Klotho is there's compelling human evidence that Klotho probably plays a role, at least in health span and maybe in longevity in people. So lots of correlative studies showing that circulating Klotho levels are associated with health outcomes, cardiovascular disease, cognitive function, kidney disease. And there are people who have a variant of Klotho, KLVS, I think is the variant designation, that leads to higher levels of Klotho. So people who are heterozygotes for that variant, so they have higher levels of Klotho, seem to also be protected against cardiovascular disease, dementia, and in a couple of studies might even live a little bit longer. Mm-hmm. So that gives us an indication that Klotho may be important for human aging. So this has led to excitement around Klotho gene therapy, things like that. I think it's intriguing. I think we're getting pretty far ahead of the data to be talking about Klotho gene therapy at this point. And one of the cautionary notes is that there's at least some evidence that people who have two versions of this Klotho allele, so very high levels of Klotho, might actually have shorter lifespan. So there's probably a sweet spot. And until we know what the sweet spot is, I'd be careful about putting in extra Klotho, for the idea that it might have some benefit in people. But again, super interesting research question. There are at least a couple of companies that are looking at ways to modulate Klotho activity, Klotho expression. So I think we'll start to see those things make their way through, a more traditional pipeline of intervention or drug development. Relationship to mTOR, they interact with each other. You can find evidence both ways. So you can find evidence that more Klotho leads to inhibition of mTOR, higher autophagy, which is one of the things that mTOR regulates. You can also find some evidence that turning down mTOR leads to higher levels of circulating Klotho. So again, I think at this point, my feeling is they're interacting with each other in this network, but we don't really understand the details of that interaction well enough to say a lot about exactly how that's working.
I want to talk a little bit about big picture zoomed out and what actually moves the needle. Rapamycin is a prescription therapy that we're excited about in the longevity space. Patients are excited about supplements, but what actually moves the needle with healthspan?
Yeah. So I think there's not a lot, I would say, outside of the kind of core that we can say for the vast majority of people is going to move the needle. And so by the core, of course, we're going to start with lifestyle factors. I think about it, and at OptiSpan, we sort of created this framework of 4 pillars of healthspan, but you can have 5, 6, 8, however you want to break it down. But essentially it boils down to, we use active words. So eat, move, sleep, connect. So nutrition, high quality diet, not necessarily caloric restriction, but high quality, not over nutrition, move, exercise. Again, there's a lot to unpack in each of these, and there's not a one size fits all solution, but appropriate amounts of resistance training so you can maintain muscle mass, lean body mass, metabolic health. Also, you want to have cardiovascular training and biomarkers there like VO2 max, I think are really useful for estimating where you're at. So exercise, sleep quality, sort of obvious on the surface, but that's a very individual thing. And I think, some people don't struggle with sleep. A lot of people do. And with age, sleep quality seems to decline. Making sure you're getting adequate sleep and it's sufficient quality sleep, super important. And then connect encompasses, in my mind, both sort of personal sense of purpose, mindfulness, but also the really important human relationship component. And I would say, I think companion animals can play a role here too, in terms of your feeling of connection to other beings, right? I think that's the one that scientists like me tend to underestimate the importance of. And I have completely done a 180 on the connect pillar in the last 3 years compared to where I was as an academic. But I think a lot of people tend to underestimate the importance of that aspect of human relationships and feeling like you've got a sense of purpose. Like there's a reason why you're doing what you're doing, I think is really important. Stress, of course, weaves throughout all of those pillars of health span, and stress management is huge as a lever that can have an impact on your health. So outside of that, there are a few things that I would put as major levers for a lot of people, maybe most people, dependent on life stage. I would definitely put hormones in there. I think I'm going to use the word optimization. The problem is we don't really know what optimal is, but making sure your hormones aren't sufficiently dysregulated that it's leading to emotional or physical problems is hugely important. And that is a big lever that a lot of people can pull and need to pull, in my opinion, once you get into middle age. And obviously it's different in women and men. And women have this thing called menopause, which as far as I know is 100% penetrant. Like every woman is going to get it. Men are different in that it's a lot. I mean, women are variable in menopause, don't get me wrong, but men I think are a lot more variable in what it looks like when you go through these hormonal changes that happen later in life, but super important for both men and women.
I blame everything on perimenopause.
I mean, I think we're starting to learn. I mean, not everything, but I think we're starting to learn that there's a lot going on there in terms of accelerated health risks. And I mean, again, it's sloppy terminology because we haven't proven it, but I think there are certainly a lot of arrows pointing to the idea that perimenopause and menopause lead to accelerated biological aging in women. So, it's again, way understudied, but people are starting to pay attention. And I think I'm encouraged that there's a lot of movement, at least in the right direction. I think that the hardest thing for me about the female hormonal health situation is just that, because of the Women's Health Initiative and what happened as a result of that, we just kind of lost a generation of experts, right? And so now people are paying attention, but we'd be so much further ahead on understanding this if that hadn't happened. But it's good to see that things are starting to go the right direction there. And I think the FDA removing the black box warning on hormone therapy for women is a step in the right direction as well. So I think there's reason for optimism. But yes, to me, that is the biggest lever most people can pull outside of the lifestyle factors, the pillars of health. And then I would say, avoiding risky behaviors, not smoking, making sure you aren't drinking too much alcohol, sort of obvious, but worth saying. And then I would say being proactive in your approach to health, using the diagnostics that we have available. And again, this is where I think we obviously get into healthcare disparities, but I do think there's a lot that the average person can do for $100 to $200 a month in the realm of proactive preventative medicine. I think that's about the 80-20 right now. And people should do that because that's a big lever you can pull to make sure that you don't get sick, or if you're on the path to disease, that you catch it early enough and you can take steps to get off that path. So those are the big levers that I can think of. I'm sure there are others, but I guess the other place I would point that we tend not to think a lot about is mental health, right? And again, just evaluating, that's a big part of health. And obviously it ties to physical health, but we kind of put it in this other bucket. So if you have mental health challenges, whether it's depression or anxiety, taking steps to get help and deal with that is another big lever that you can pull. And a lot of people do. And again, our culture is sort of creating this, situation where just because of the nature of social media and what's happening in the world, anxiety is an epidemic for sure. And so if you're struggling with that, there are lots of steps to take. That's getting to an area that I'm not an expert in. I've learned a lot, but there are lots of smart people who have advice on how to deal with anxiety and depression and other mental health challenges that people face. Being aware and taking action there, I think, is another big lever that people can pull. And so those are the big things. And then we get into the incremental stuff. And there are some things that have incremental value. Some supplements that I put in that bucket, particularly deficiencies that you can fix through supplementation, vitamin D, omega-3. that might even be it's not a big lever for most people in my view, but it's sort of something, it's a no-brainer. You should do it if you can measure it and you know that you're deficient. But then when we get into other supplements, there are some things I think have value, but I don't think they're going to really move the needle for most people. And there are some things that are going to be individual. Like I said, rapamycin for me had a big effect. It had a big effect on my quality of life. I don't know if I'm going to live longer, but it had a big effect on my quality of life. I think there are people with things like rapamycin, SGLT2 inhibitors, things like that, where that becomes much more individual. It can have a big effect for that individual, but I don't think there's anything else, at least in the geroprotective realm, that I would point to that we should talk about for everybody at this point.
Kind of in that vein, what are your pet peeves in this field? What are the things that I think get a lot of press or get a lot of social media attention that really don't move the needle?
Yeah, I mean, well, so we already talked about clocks. Clocks are one of my pet peeves, mostly because of the misinformation and the fact that they're being presented to people in a way that isn't honest. I think, honestly, the things that bother me the most tend to be the things that are being dishonestly represented to people and could be harmful to people, harmful being economic damage or health damage. So supplements are a big challenging space. Like I said, there are some supplements that I believe in. There are a lot of supplements where I'm just like, I don't know, maybe not. The problem in the supplement space, I think, is the deceptive marketing. And I have yet to find a company that is selling longevity supplements that is not lying to consumers, in my view, or at least deceiving them, intending to make them believe something that isn't true, even if the words themselves don't say something that isn't true. So deceptive marketing around supplements, I think, is really, really problematic in this space. And most people are not equipped to be able to evaluate that. Related to that, I am very concerned about academic scientists who are involved in selling biological age tests or supplements. I think that the general public will assume that somebody who has an affiliation at Harvard or MIT or pick your favorite university is giving credibility to the supplement or the test that they are selling. And then when that is deceptively marketed to consumers, in my view, that is unethical and a real problem from that perspective, but also because it makes the field look bad and it creates a credibility problem for the field. So
we lose credibility as a whole when that happens. And yeah. I think we have to answer to patients when they've kind of been deceived by this supplement. I was told this would save my life. I saw this on TikTok, so I bought it at 3 a.m. And, you know.
Tough. I mean, in the academic world, I totally get it. We're not on the academic side, but there's plenty of physicians who have become spokespeople for various things, and they don't have any real evidence to back up what they're claiming, which makes it really tough for us to say, no, I'm a doctor too, believe me, right?
Yeah, no, I agree. It's a real challenge. And I think, obviously, I don't have the answers for how you have those conversations. I think helping people to recognize what is and isn't known and where the uncertainty begins and ends, I think is probably the best we can do. And then try to let people make their own decisions. But also, I think pointing out when people, whether it's an academic, medical professional, an influencer, say things that are demonstrably untrue, pointing that out, and then simply, making the point, if somebody lies to you once, they're probably going to lie to you again. Why would you trust this person? And then it's up to people. Like, if they want to continue to trust these folks, that's on them, in my view.
Yeah, I think you're right. We touched a little bit earlier, and you'd mentioned something about AI in this space, and I wanted to get back to that. I know we've been leveraging it a little bit in how we do the workups on our patients and how we analyze the data that comes out of those workups. What are you most excited about, I guess, moving forward on how AI is going to change things for us? Because I think there is, there's broader implications on just healthcare in general and reducing red tape and stuff. But I mean, specifically in the geroscience field.
Yeah. So there's lots of ways I think AI is going to impact geroscience, just like there's lots of ways it's going to impact every aspect of life. There are two that I think a lot about right now. One is on the research side, which is more around how these tools can enable us to interpret these very, very large data sets to identify either novel signatures, novel patterns, or maybe even be hypothesis generating. And the clocks are an obvious example of this. This was before, the current batch of LLMs and how we see how powerful those are. But that's how the clocks were developed. It was using AI tools to pick out the best, in the Horvath clock case, 353 methylation sites out of 3 million. That's a clear example where even tools from 10 years ago were useful in identifying these novel predictive signatures for chronological age in that point. So those are going to just continue. And as we start to generate larger human data sets from these large population studies, we need those AI tools to be able to interpret that data and identify correlations and signatures that would be really hard for individual human beings to identify. So that's going to be one area. Intervention prediction, maybe using AI to look at what we know about the biology of aging and predict new drugs or other targets to go after to slow aging. That's gotten a lot of attention. So far, I have not seen a single case where an AI predicted intervention proved out. Doesn't mean it's not going to happen. Mm-hmm. I haven't seen any data. And my concern there is that the intervention set we're working with right now is so small and limited. If you put in rapamycin and SGLT2 inhibitors and metformin, you're going to get out things that look like rapamycin. So we're going to find things that we already know about. I don't know yet that AI is going to be super powerful there. On the clinical side, the area that I think about a lot and we're working on, as are others, is much what you described, right? So using these tools, particularly the advanced large language models, to help us both integrate the data we're collecting from a whole bunch of different tests and diagnostics in the context of what's already clinically established, to identify patterns and then report it back to the doctor and at some point the client in a way that is useful for them. We've been doing that for 18 months now, since the first sort of iteration of ChatGPT came out internally. We're not rolling this out to patients. At least initially, they weren't even close to being ready. But I have been, and this is probably your experience too, I have been amazed at how good the tools have gotten. They're really, really good. They're not perfect, but human beings aren't perfect. So I definitely see a time in the pretty near future where we will have what I call AI healthspan agents that can do exactly that, can take all of your data from the different diagnostics. Optimally, it'll be longitudinal data you've had over many months or years, integrate it, build in the wearables, the trackables, the real-time data, and give you feedback. And so again, this is where I think we kind of have to wait and see how the regulatory landscape evolves, how comfortable people are with the AI tools, how well the AI tools perform. To what extent will these tools be allowed to give medical recommendations, right? At first, they're not going to be. Mm-hmm. And I think that's appropriate. They shouldn't be allowed to at first. I very much believe right now, doctor in the loop is the only way to go. I am actually concerned about some of these direct-to-consumer companies that sell diagnostics to people and then don't give them any help after that. Yeah. So that's a different topic. But I think there will come a time, and I don't know if it's 5 years from now, 10 years from now, 2 years from now, where people feel really some people feel really comfortable with these tools now. I've put all my data into ChatGPT and said, hey, tell me what this means, right? So some people just take it as granted that ChatGPT is going to give you the right answer. You shouldn't do that right now. But there will come a time when it's pretty good. And so I don't know what that looks like, but I can see us get to a point where pretty quickly, again, 2 years, 5 years, we've got these very powerful AI healthspan agents that can give you 24/7, 365 feedback and will give you recommendations that are designed, hopefully in partnership with your physician, to optimize your healthspan. I don't think I see that path clear as day where that's going to happen. I just don't know how long it's going to take, and I don't know how the regulatory environment's going to evolve. But optimally, there will be a collection of physicians who really lean into these tools and can become the docs who can work in partnership with these tools with the people who want to use them that way. The last thing I'll say on this, and again, maybe I'm being naive, but I hope not. I think that this is the opportunity to really deal with some of the major healthcare disparities that we have right now. Because these tools are not prohibitively expensive, everybody in principle should be able to have access to at least a rudimentary healthspan agent. Now, they may not all be able to have access to the best docs in the world who can help them use those tools, but I think it's going to be better than what most people get right now. And then it's going to be very much up to the individual. Do they want to use those tools? And do they want to do the things that the tool tells them they need to do to optimize their health span? There's obviously a huge behavior modification piece, but I do think this is a real opportunity to address a lot of the healthcare disparities that are out there. It's not going to fix everything, for sure, but I think it can. I think it can be a big help. So I'm really excited about where things can go.
I think you're right about that. Your last sentiment. It's interesting. I mean, it's not like people don't fundamentally understand that they should eat properly or exercise and sleep better and cut the alcohol.
Yeah.
But having someone tell you exactly how to do those things is much more valuable, and why you're doing those things, rather than just having the basic knowledge that smoking is bad and I should sleep 8 hours a night. Right. And that's where this AI thing does get interesting, because it is pretty good at giving you a plan. If you give it proper input data, it spits out a plan that can be pretty evidence-based. And at least it's a good starting place for people, which I think is pretty interesting.
And it's come a long way. We started 2 years ago, and the technology, this wasn't even around. And each month it just gets better.
Yeah, they upgrade Claude or ChatGPT, and it's like, oh my gosh, this same thing took like 2 days 3 months ago, and now it's doing it in.
We were like, I wish it would do X, Y, and Z, and then 2 weeks later,
boom, it heard you. Yeah. The only thing I would add to that, I think you're right. Most people do, in general, know what they should be doing. But I think when it comes to the specifics, like you're saying, it helps to have somebody tell you in detail what you should be doing. I think when it comes to the specific, I'm still often surprised at how many people don't know the things that I sort of take for granted, right? Now that I've been in this space for a while. Even simple things like being able to read a nutrition label, walk through the store and understand, where are the added sugars, right? And those are things where these AI tools also can be quite helpful. And, again, depending on how you use them, potentially could tell you in the moment, like, okay, that particular product is not aligned with your health goals. Why don't you consider this alternative, right? Or, you're in your car, your wearable detects that your blood pressure has spiked when we get, continuous blood pressure monitors. And it's like, I can see that you seem to be stressed out. Perhaps you should consider deep breathing, whatever the technique is. So to sort of just like in the moment, de-escalate that sort of stress before it gets to the point that it creates a major event for your day, or maybe even a major event in terms of a heart attack or something like that. So I think there's all sorts of ways this could evolve. People are going to be uncomfortable. Some people are going to be uncomfortable with the idea. Some people are going to be uncomfortable with the idea that the AI might be manipulating you. Like, is it controlling your behavior to get you to calm down? But I would argue that's probably a good thing. If it's, as long as I would think of it maybe as more like emotional tuning. So I'm interested to see how this evolves, but I think there's a lot of opportunities here.
It's a benevolent AI.
Yeah, hopefully.
I always say thank you when I use ChatGPT, because when they take over the world one day, I just want to be remembered as I was always gracious.
You're on their team.
Yeah, you yell at it.
There's all sorts of interesting human psychology and behavior that goes into using these tools. Every once in a while, I find myself feeling a little embarrassed about the question I asked ChatGPT, and then I'm like, no, wait a minute, it's just ChatGPT. I don't need to be embarrassed about this.
There's so many different wearables right now. Are there ones that you use?
I mean, I've used Oura Ring for sleep tracking. I personally found that with Oura Ring, I felt like there's about a 6-month value proposition there for me personally. And then I kind of knew what I knew. I use my Apple Watch all the time to track, my workouts and things like that. That's really the only wearable that I use a lot is my Apple Watch, because it just does so much. But again, I think it's a very personal thing, and what you are most interested in. If there was a really good, I think, continuous blood pressure monitor, I don't have high blood pressure, so it's not an issue for me, but I'd want to try it. I do like CGM. I do that periodically. I think that's a very useful educational and behavior modification tool. I don't think it's something people need to do all the time, continuous glucose monitoring, but I do it maybe once every 6 months, just to kind of, see where I'm at. And I always learn something new every time I use CGM.
I'm kind of on the same page as you. I also like the latest AirPods. You don't have to wear a heart rate monitor anymore because when you're exercising, they're pretty good.
Right.
I've tracked it versus like a chest strap, and it's almost identical data.
Right.
So it's super helpful when I'm doing zone 2 and zone 5 exercise. What other questions do you have?
Can I tell you something? I'm going to delete this from the podcast. I had a dream last night about not that kind of dream. And I woke up and I was like, because he yelled at me in the dream. And he's like, why are you so nervous?
Literally, like had a nightmare.
That you yelled at her?
No, that you.
That I yelled at you?
Yelled at me.
For being nervous.
Or no, just in general. It was something like, I was so worried about the technology because we're good at seeing patients. I would say technology is not in our wheelhouse.
So here you go. You can use this. What the hell is wrong with you?
That's going to be on the intro. That's great. I wanted to ask a little bit, just because I know this is near and dear to your heart, with the dog aging project, with NIA funding and everything getting messed up with changes in government. Where is it at right now, and what are the plans for when it's going to be completed?
Sure. So first of all, maybe useful to just define the dog aging project and the overarching goal. So there's really two parts to the dog aging project. One is a large longitudinal study of aging. It's purely observational, where we are just following dogs living with their owners and collecting as much data as we can about the dogs, mostly through owner surveys, some through veterinary records, some through biological samples. So genome, epigenome, metabolome, things like that. And that's about 50,000 some dogs in the longitudinal study today. Then there is the smaller clinical trial, which is a randomized, double-blind, placebo-controlled veterinary clinical trial of rapamycin. That currently is about 250 dogs. It will eventually be more than 500 dogs, half rapamycin, half placebo. There, the goal is to determine, does rapamycin increase lifespan and slow aging in dogs? So in the initial grant, which was funded in end of 2018, those two parts of the project were co-funded. They were both funded by the large grant from NIA. That grant ended in 2023 and was not refunded. And I have my feelings about that. As you can imagine, I would say lots of swear words if we talked about it, so we shouldn't talk about it. And it took a couple of years to get the clinical trial refunded. That has since been refunded, so that is enrolling. It's a 5-year grant. The trial will be done before the grant ends. So that is going to get completed. The longitudinal study has not yet been refunded. The grant was submitted a month or so ago. So fingers crossed, hopefully it will get refunded. We managed to keep the lights on through philanthropic funding. We have a nonprofit called the Dog Aging Institute. It's a 501c3, dogaginginstitute.org, shameless plug if anybody wants to support it. So that kept the lights on and allowed us to keep at least the core team intact. So hopefully, like I said, the longitudinal study will be refunded, and that will allow that project to continue for another 5 years. The other thing I'll say on this topic, and again, whether it's done through the dog aging project or in the private sector, I don't really care. I do think it is a message I want to communicate to people that slowing aging in our companion animals is a solvable problem in 5 years. We know probably 20 things that slow aging in laboratory animals. And we can measure it. We know how to measure it. We can do this safely. We can test these things in companion animals. I can't say with 100% certainty, because I'm a scientist, that some of those are going to work in dogs, but some of those are going to work in dogs. It's going to be the case. We could solve that problem. This is just a resource allocation problem. If people care about their companion animals, we could do this. I don't know how much it would take, but it would take less than $100 million. That sounds like a lot of money, but if you look what we spend $100 million on crazy stuff all the time, that's a drop in the bucket. So this is all just to say, this is only a resource allocation problem to increase healthy lifespan in our companion animals by 20+%. Seems to me like it's a no-brainer. Somebody needs to do this. Some rich person needs to get off your ass if you care about your dog and do this. Okay, that's my message.
Any rich people listening, this is what you're going to do.
Yeah. Just imagine how much you would be beloved if you slowed aging in people's companion animals. This is worth it. Go do it. And I don't have to be involved, but I'm happy to tell you how to do it if you want to know.
Dogs age faster or have a shorter lifespan than we do. So it's easier to track over a period of time than it is in humans. what other biometrics are you going to be tracking in the intervention and the placebo group?
Yeah. So two things to say about that. I'll talk about all the things we're measuring in a second. So you mentioned dogs age faster, which is absolutely true, right? The other piece that it makes dogs very powerful for this kind of a study is they share our environment, which we can't, recapitulate in the laboratory. In fact, we try really hard not to. We try to control the environment. So that's another, I think, important aspect here that makes this informative about human biology as well. Okay. So in the trial, lifespan is the primary endpoint. So that is what we are statistically powered for. Again, this depends a little bit on the demography, and so it's a little bit of an estimate, but we believe we are statistically powered to detect a 9% change in lifespan, which is towards the lower end of what's been reported for rapamycin in mice. So that's why we have the size of the study and the enrollment criteria that we've got. So that's the primary endpoint. Secondary endpoints include heart function measured by echocardiogram. That's because in mice, several labs have seen improvements in age-related heart function from rapamycin treatment. Neurological function measured through a bunch of different neurological parameters, activity, disease incidence, and then we have exploratory endpoints. Oh, and cognitive function as well for secondary endpoint. Then we have exploratory endpoints looking at things like metabolome, microbiome, epigenome, blood chemistry, inflammatory markers, things like that. So we're trying to take as broad a look as we can, given the constraints of working in companion animals and funding, to take as broad a look as we can at healthspan. One of the challenges people often don't appreciate about doing these kinds of studies in dogs is that many of the reagents, I'm talking about things like antibodies or ELISAs that we would use for quantitative measurements, we have them for humans and we have them for mice, but we don't have them for dogs. So there are things we would like to measure that we just can't measure in dogs because the reagents haven't been generated for veterinary medicine. But the majority of things that we are interested in looking at, we can measure within the context of the clinical trial.
That's pretty cool. I think we're going to be super excited to see the results once you're done with full enrollment and you're getting down to that 5-year mark.
And who doesn't love dogs? I mean, you would probably win a Nobel Peace Prize for that.
There's someone else vying for that already.
Yeah, I would just be happy to be able to demonstrate we can slow aging in dogs. And again, I mean, look, everybody's got an ego. I would love to be the person to do it, but honestly, I'll be happy when anybody does it. And I think that one of the things that has been really great is to see that the template that we built at the Dog Aging Project is now starting to be moved into the private sector. So companies like Loyal that are going through the FDA approval process for aging in dogs, that's really encouraging and exciting. And so, like I said, this is a solvable problem. We'll get there. We could get there in a few years if people would actually put a relatively modest amount of resources towards this.
All right. Well, this was awesome.
Yeah. Thank you so much.
I enjoyed it.
You made our day. Truly, we appreciate you being such a prominent voice in the longevity space. I think there's a lot of charlatans and people with ulterior motives selling things, and you brought so much credibility and just truth to a newer space in medicine, and we're so grateful for that. So if our listeners who want to learn more about you, your work, the Dog Aging Project, want to know more, where can they find you?
Yeah, so best place is the OptiSpan podcast, which is on YouTube, OPTISPAN. It's Optimal Health Span, just mashed together. Lots of content there. If you enjoyed this, there's plenty more where that came from. I'm also on Instagram at mKaeberlein. I'm also on X, but I'm not very active on X these days, at mKaeberlein. Dog Aging Project is dogagingproject.org. If you have a dog, we're still enrolling dogs into the longitudinal study. So I'd absolutely encourage you, if you want to participate in science of longevity, nominate your dog to participate in the study. If your dog meets the criteria for the rapamycin trial, we're still enrolling dogs into that as well. So you could potentially participate in the clinical trial as well, and definitely would encourage anybody who's a dog lover to think about doing that.
Geographically, where do they have to be?
So in the United States, that's it. Although we do have a limited number of clinical sites. There's about 21 or 22 at this point. So obviously it's easier if you live close to one of the clinical sites. So the dogs come in for the clinical trial once every 6 months. I should clarify though, that's only for dogs that are in the clinical trial. for dogs that are in the larger longitudinal study anywhere in the United States. Unfortunately, it's not yet international. I wish it was. Someday we'll get there. But right now, any dog in the United States can participate in the longitudinal study. And then there are eligibility requirements and geographic location near one of the clinical sites for the clinical trial.
Awesome, Matt. Thank you so much.
You're welcome.
We really appreciate you being kind of the adult in the room of the longevity space.
I wish I could be the little kid in the room. There are days.
Well, then we wouldn't need longevity, right? This has been awesome. Thank you so much. Hopefully we can have you back on at some point.
Thank you. This has been a lot of fun.
All right.
We'll let you know if Nisha has any more nightmares.
Hopefully not. I don't enjoy being in people's nightmares. All right.
Take care.
Take care, guys.
Thank you for playing the long game with MD Longevity Lab. You can visit us at www.mdlongevitylab.com to learn more about how we can support you on your journey. Stay connected with us on social media at MD Longevity Lab for tips, updates, and behind-the-scenes insights. If you enjoyed today's episode, we'd love it if you subscribed, left us a rating, or shared it with someone you know who's also playing the long game. Thanks for listening. We'll see you next time.